Good evening, everyone. This is Jeff Robertson from Newmarket, Ontario, wishing you all a pleasant evening. I'm the Executive Director for the PKD Foundation of Canada, and we are thrilled to have you all in attendance today. It's going to take a few minutes to get everyone into the room from the waiting room. We have over 600 attendees this evening scheduled to join us, so it's a testament to the hot topic and sensitivity of this evening's webinar. But as I prefaced earlier, we're thrilled to have you here, and thank you for joining us. And of course, thank you to Otsuka Pharmaceuticals for allowing us the opportunity to present these educational webinars in the fashion that we are. It's a blessing in these unprecedented times for us to be able to share these educational events online and still provide the level of educational support that people have come to expect from the PKD Foundation of Canada. So of course, today we're here to learn from one of the most brilliant minds in PKD research, Dr. York Pei from Toronto General Hospital, UHN, on the COVID vaccines, something that is impacting all of us as Canadians and everyone around the world. We have plenty of questions to be asked throughout the evening, and there's also a question box for you guys to type in your questions if you didn't have a chance prior to this evening's event. So we will be picking from the live questions as well as the ones that were sent in after Dr. Pei's main presentation. So without further ado, I'll introduce the man of the hour, and then we'll kick things off, and Dr. Pei will be able to get things started. Dr. York Pei is a professor of medicine at the University of Toronto and a staff nephrologist at the Toronto General Hospital University Health Network. He obtained his research training in clinical epidemiology at McMaster University and later on in human molecular genetics in Toronto. The main theme of his research program is to identify genetic factors involved in the initiation or progression of common kidney diseases as potential targets for novel diagnostic tests and therapies. His research focuses on genetic, genomic, and translational research of 3 common kidney disorders: autosomal dominant polycystic kidney disease, IgA nephropathy, and idiopathic nephrotic syndrome, and is supported by grants from the PKD Foundation of Canada, the Kidney Foundation of Canada, Physicians Incorporated Foundation, and the Canadian Institutes of Health Research. It is my distinct honor to welcome Dr. York Pei this evening.
Thank you very much, Jeff. Is the voice okay? The level of yeah, okay. So so thank you very much for joining this webinar today. And I thought that I will talk to you about the COVID-19 vaccines, which is the main topic. But before we do that, actually, if I can go back, sorry. Sorry, I seem to have some problem with the okay, yeah, so I thought I would just present an overview of the COVID-19 pandemic, some of the feature about this disease, which we are constantly learning, and its potential impact, which we all feel before going into the topic of the day, and then follow up with the progress in COVID-19 vaccine development, because there are multiple candidates, but focus specifically on the mRNA vaccines, which there are 2, and they're approved for emergency use in a number of countries, including Canada. And then I would try to end with trying to give you my thought about the whole picture on the pandemic, how it likely will end, and what we need to do. So COVID-19 stands for coronavirus disease 2019. So it's caused by a virus, so-called SARS-CoV-2. So it's a novel coronavirus related to the viruses that cause the common cold. And this virus originated from Wuhan in late 2019. And we now know that it has a variable kind of presentations. And because this is a respiratory virus, fever and cough is the most common in about 1/2 of patients who present. But there are other features such as headaches, muscle aches, sore throats, diarrhea, and an interesting feature such as loss of smell and taste, which is very specific for this disorder. One thing that is important to point out is the severity spectrum of this disease. It is a bit worse than the influenza in the sense that even though 80% of the patients affected in the clinical presentation have very mild disease and generally will not need very much in-hospital intervention. About 20% would end up in the hospital and 15% that would result in management requiring hospitalization for the severe pneumonia, and then 5% requiring critical care because of multi-organ failure and requirement of intubation, for example. And overall, the case fatality rate varies somewhat, but it's in the range of 1 to 2.5%. What is also important to bear in mind is that there is another group of patients that may be infected, but they have no clinical symptoms. So these are the asymptomatic cases. And there are various estimates, but the most recent estimate that I come across is between 20 to 30%. So these individuals are well, they have no clinical symptom, but they're actually infected and shedding virus and become a carrier that can result in community spreading, which is the real challenge in management and control of the pandemic. So there are a number of high-risk groups that we have learned which are predisposed to the severe and critical disease of COVID infection. And I list a number of these factors, and I will go into them in more detail. First of all, age. The older you are, the higher the risk. So for example, the case fatality of someone who is less than 60 years old infected is 1.4%. By contrast, over 60 years of age is 4.5%, and much higher if you're in the 70s and 80s. Other risk factors include chronic heart, lung, and kidney disease. And kidney disease, I want to specify and a little bit because this is of the interest of the PKD audience and to kidney disease community. So I would say that probably kidney disease is not all kidney diseases, but kidney disease complicated with more advanced kidney failure. So I want to kind of specify that because PKD is a spectrum. Many of you who may have PKD may have fairly normal kidney function. So your risk of severe disease may be only minimally elevated. But if you have chronic kidney disease stage 4 or 5, very close to dialysis, or when you're on dialysis, then you have much higher risk of having severe disease. So I want to kind of clarify this point. People who are overweight have increased body mass index, obesity. People who have more serious kind of cancer, organ transplant recipient may also have increased risk. And that's probably because of the immunosuppressive drugs that they are on that reduce the ability of the body to fight infection. And For the organ transplant recipient and particularly, for example, kidney transplant in which some of the PKD patient may have, I would like to specify that there may be a difference and likely a difference between people who have a recent transplant versus those who have a long-term transplant. And the risks are probably quite different. People who are on higher doses of immunosuppression because of recent transplant probably can be susceptible to more severe disease than someone who have a transplant for many years on low dose immunosuppression. The immunosuppression dose may also be relevant, and later on we talk about vaccine in the sense of whether you would be able to mount a robust immunity response to the vaccine and therefore result in the protective benefit. If you're on active immunosuppressive treatment, it may be difficult for your body to mount a immune response. So you may actually not be protected by the vaccine. Whereas if you are stable transplant recipient on very low dose immunosuppressive drug treatment, the response may be almost close to normal. So a number of mitigating and control strategies have been proposed and many of us are practicing. And I just want to emphasize whether vaccine or not, we are likely going to need to employ all this strategy to keep each other safe. So I want to emphasize the importance of masking, social distancing, frequent hand washing when you're outside your home environment. And then in the more public health activities, contact tracing and widespread testing, targeted testing, testing in high-risk grouping, such as long-term care facilities, dialysis unit. All these are being done and hopefully help to minimize the chance of outbreak. And then we are in a lockdown right now, which has very severe societal disruption. But unfortunately, when things are not in control, this is a necessary exercise to get the cases down to a manageable level so as not to overwhelm the hospital and particularly ICU capacity. Eventually, and part of the talk today will allow us to eventually break free from this pandemic, and that is by vaccination in a massive scale, a population level, to achieve herd immunity. And for this to happen, it would require vaccination in or infection, whether it's natural infection or by active vaccination in at least 70% of the population for this to allow us to eventually break free from the pandemic. So I want to just talk a little bit, like despite the tremendous challenges we have faced over the past year with COVID-19, is also an amazing witness of progress in vaccine development. And I just want to remind all of us that typically to develop a vaccine, it takes many years. From the preclinical stage to phase 1, phase 2, and phase 3 clinical trial, a lot of regulatory oversight and barrier. And all these have been completely collapsed and shortened to the fact that we now have at least 2 vaccines that are put into clinical use. And so this is pretty tremendous and amazing progress and really allow us to see light at the end of the tunnel. So before we talk about the mRNA vaccine, which Jeff have asked me to talk about specifically, I want to kind of list a number of kind of vaccines that are very promising, including the 2 that we're going to talk about tonight. So the two mRNA vaccine that we're going to talk about are from Pfizer and Moderna over the top two. And I'll talk more about it. Each require 2 doses to extract its maximal benefit. But there are additional vaccines that have been developed in late stage clinical trial, and we likely will use some of them. And when they become available, it will potentially help us to shorten the timeline for targeted population vaccination. And I want to point out for you that the third one is AstraZeneca, in which they already had published some data, again, a 2-dose kind of a regimen, and which I will show you some results a little bit. And then the additional vaccine, for example, those that developed by Janssen, Novavax, Sanofi. And I think these are using different technology, the more traditional technology using adenovirus to make the protein and or other technology. And so I think I want to say that, and this is just in North America or in mostly European country. In Asia, in China, in Russia, they have their own also homegrown vaccine that are also have undergone late stage clinical trial and are being deployed. So I think that these are all things that will eventually help to solve the pandemic problem. So I want to focus a little bit on the mRNA vaccine. I want to explain to you what is the uniqueness of mRNA vaccine. So mRNA stands for messenger RNA. So messenger RNA is part of the gene transcription unit that allow us to make protein that are based on the instruction of the DNA. So we all use mRNA in our body cells to make different kinds of proteins, and the same for the virus. But what is important for this virus is they have on the surface of the virus a specific protein called the spike protein, which is 3 identical units kind of intertwined together. This spike protein will bind to the receptor in the human cells and allow the virus to enter into the cell and infect the cell. So this is a critical protein for the first step of viral infection. And so it's a major target. And in fact, all the vaccines that I mentioned target this protein. So the mRNA technology is very unique because you actually don't need to make the protein and then isolate and purify the protein and then to then make the vaccine. You actually use the, you make the copy of the viral spike protein in the form of the messenger RNA. You put it in a lipid nanoparticle. So these are very small particle that are made up of fat, basically. So, and because the cell membrane is also fatty, this fat and fat will allow the two, nanoparticle in the cell membrane to fuse and deliver the mRNA into the human cells. And then in the human cells, so this is like once we get the injection in the form of a vaccine, so all these tiny particles will be flowing from the bloodstream like to the different parts of the organs and tissue, and then to the different cell and fuse with the cell membrane without really needing any kind of sophisticated help because lipid and lipid are very compatible, and it would just go through and then kind of put the mRNA into different cells. So the human cells will then be tricked to read this messenger RNA and make the viral protein and express it on the cell surface. This is a foreign protein, so it will be detected by the immune system, which survey anything that is different from our cells, and then create antibodies and then trigger the different kind of cell-mediated immunity. And this is the way that the vaccine will allow us to develop defense against the virus before even getting infected. So that if you do get infected, but you have been vaccinated, you will either have a very mild form of disease or no disease, because you have all the machinery to fight the virus and not letting them to take hold of the host and then replicate and cause widespread destruction. So this is actually a new technology. It has been put in proof of concept, but have never been used in human. It's been used to make a vaccine and tested in monkeys, for example, and then shown to be effective, but never in any kind of large scale in the patient population. So this is now happening. So there are certain uniqueness about the messenger RNA. Messenger RNA are inherently unstable, so it needs to be stored. And for example, the Pfizer vaccine requires -80-degree freezer to store them. And then once they get thawed and then diluted to this delivery solution, then it only have a short time to be administered. So this vaccine is challenging to use for unless you have -80 freezer, you have very high throughput delivery system for vaccination. So it's not really suitable for community delivery like the flu vaccine, which the general practitioner can take it from their own fridge, -40 at 4 degrees, and the vaccine is still good. So it has its limitations. So that's why all the Pfizer vaccine are being delivered in a few centers, and then people will have to go there to get the vaccination. The Moderna vaccine is a little bit better. It requires -20-degree storage. It is much more stable and than the Pfizer vaccine. So it may be a better vaccine at this time for community use, but still challenging is -20 cold storage. So both vaccine, when it's injected into the muscle and require 2 doses, will then deliver the messenger RNA to all the cells in the body. And then from that, the messenger RNA get read by the machinery of the cells, and then the viral protein get expressed, and then elicit the immune response, both antibody and cell-mediated immunity. One other feature which are relevant when we talk about side effects is that both vaccines require a substance called PEG, or polyethylene glycol. So for those who are familiar with chemistry, polyethylene glycol is part of the family that make antifreeze, and it is kind of like an antifreeze to help to stabilize the messenger RNA, and it is thought that the more severe allergic reaction, which I'll talk a little bit later, is directed against this chemical. Someone who are allergic to this, because the vaccine contains this chemical, can result in very severe allergic, but rare reactions that are potentially serious. So I'd like to talk a little bit more about these 2 vaccines, the Pfizer and Moderna mRNA vaccines. And both clinical trials have been recently published. And then based on the results, they have received Food and Drug Administration and Health Canada approval in US and Canada, as well as in other countries such as Germany and then UK. So these trials are the really standard kind of final phase of testing new therapeutic in human. So they are the so-called phase 3 double-blind, placebo-controlled, randomized control trial. So it's a bit of a mouthful. So what does it mean? So double-blinded, it means that you're giving something that looked like the treatment, but it's a dummy, in this case, injection. So people who enroll in this trial, they will get injection, 2 doses at a specified time, but you don't really know whether it's an active messenger RNA vaccine or placebo. And both of these trials are fairly large scale and quite typical for vaccine trial, and I'll explain why. So the number of patients in the trials, Pfizer trial was 43,000 plus, Moderna trial 30,000 plus. The reason for such large number is that you want to have a short observation period because of the pressure of trying to know whether the vaccine works, so that you can start to deliver it out. So you don't want to have a 1-year study. In fact, the study is pretty short once they enroll enough patients. And I'll mention the specifics later. So it's 1-to-1 randomization. So 1 patient assigned to placebo, another will be to the active treatment. And both trials require 2 doses. Because it is such a big trial and you want to get the results quite in a short time, you can't have very sophisticated outcome, and you can't have, so the efficacy measure is the number of clinical cases that are confirmed by RT-PCR, which is the gold standard for diagnosis COVID-19. At least 14 days after the 2nd doses. So I'll show you some graph to show you what this means. And you can then compare the active treatment group against a placebo. If the active treatment is effective, then you will see quite a fewer number of patients with this clinical disease compared to this placebo. And the magnitude of that will allow you to define the degree of protection. For safety, they will measure all the adverse event related to the injection. And having the placebo group is actually very important, because some of the adverse event that you think are really related to the vaccination may actually not, because in the placebo group, if it's the same number as the placebo, then it's not a real adverse event. So one limitation about this, because it's really a short study, so only a median follow-up of 2 months. So this is the efficacy data. So on the left panel is a Pfizer trial. So on the y-axis, the vertical axis, you can have the cumulative incidence or not cumulative number of the clinical cases that are confirmed by RT-PCR. On the x-axis, the horizontal axis, is the days after dose 1, but actually things start to be counted after 21 days, which is the end of the 2nd dose. Okay, so the small panel on the left-hand side, you can see the blue line, which is placebo, and the red line, active treatment, is identical until it starts to, the 1st dose is given, and then the 2nd dose, and then some lag time for the recipient to develop immunity. Then you can see the difference. So what is interesting is by 1 week after the 1st dose, you're already starting to get an idea about protection. So the 2 lines actually start to diverge. So the degree of protection is quite striking, it's 95%. And actually, I would say that both trials have such similar results that I would consider them really to be equivalent. So on the right-hand side is the Moderna trial, and so a very similar kind of design. And then on the vertical axis is the cumulative incidence of the clinically defined infection cases. And then on the, so you can see that at time 0, everybody that there's no event. The first few days, there's not really any significant difference in the event. But by the third week, like after the first dose, and for the Moderna vaccine, the second dose is given 4 weeks after. So there's a second arrow. So even before the second dose is administered, you can already see the curve to be slightly different, that those who received the active treatment shown in this red line have fewer patients infected before they even get the second dose. So even one dose have protection. And in this case, and both trials suggest that even after one dose, you may actually get significant protection already. And in the case of the Pfizer study, even after one dose, you get about 80% protection. When you get the full 2 doses, you can get 95% protection. So what about side effects? Actually, before we talk about side effect, there's a few other points that I want to mention from the study. Both vaccines, the evidence that they protect against severe disease. So there are subgroups of individuals in the clinically infected cases that have more severe disease than those who had milder disease. And you see many more patients who had severe disease in the placebo group, but very few in the vaccinated group. And then the subgroup analysis of both trials also suggests that age did not make any difference in terms of the degree of protection. That is to say, if you're older, you still get the same kind of protection as a younger individual. So as I mentioned, 80% efficacy after the first dose. But there are significant transient side effects, and which can be local or systemic. And I'll kind of explain a little bit. Local meaning that it's related to the injection site. So remember, the vaccine is injected into the muscle, usually in the upper arm. So people who may have pain or soreness and discomfort, and from that, so that would be classified as local injection site adverse event. So you can see this is the graph taken from the Moderna study, that 84% have this kind of adverse event. So like any vaccination, there's a good chance you will have a sore arm for a few days, but this is self-limiting. The systemic event may be a little bit potentially more kind of make you feel a little bit uncomfortable. And the systemic adverse effect, most of them are still self-limiting and generally minor. And they include fever, headache, muscle ache, fatigue, like you have a flu. So, but remember, even in the placebo group, they didn't get the active treatment. You still have 20% that have the local injection site effect, and about 1/3 have the systemic effect. So that is important, and because these people did not get their vaccination, they just have a dummy vaccination. So having the placebo group actually allow you to get some sense about the true magnitude of the side effects. So when you look at the difference of that, that is really due to the vaccination. The more important and much more serious side effect is quite rare, and it is anaphylaxis. So anaphylaxis is a severe allergic reaction. And why it's potentially serious is that your mouth, your tongue, your airway can get swollen, and then it could compromise your breathing, and some people can suffocate. So it's a medical emergency, and then usually they're treated with adrenaline and other type of medications, such as systemic steroids. And But this is quite rare. It's estimated to be 1 in 100,000 individual who receive the vaccine. All these data are limited somewhat by the observation period, median observation of 2 months. Okay, so that's the limitation of the data that we have today. We don't really have longer than that observation, and but still a pretty large number of patients. So I want to kind of talk a little bit about the severe allergic reaction. So you may have read on the news that there have been like people, and including a couple of healthcare workers, who had a background allergy. They have severe allergy, and then they had the vaccine, and then develop anaphylactic reaction. So one thing about anaphylactic reaction is if you recognize it and you treat it, it's completely reversible. It doesn't result in any kind of permanent damage, even though it's scary. Okay, because if you cannot breathe, like that is potentially life-threatening. So one of the things about precaution is if there's any potential from this kind of immediate allergic reaction, which is typically associated with the immunoglobulin E response from the mast cells, and it's thought to be related to this polyethylene glycol 2000 preparation. So the body of these individuals have never seen or maybe this chemical and is allergic to it. So when it's exposed to it, it just result in the mast cell degranulation, a lot of histamine release, and so they can get this kind of anaphylactic reaction. And another manifestation, if it's milder, is hives. So you get itchy kind of skin lesions throughout your body, and the hives can be delayed. And another cause of the hives is what is called serum sickness, which is not IgE mediated. And typically it would occur at least, usually at least 2 weeks after. And again, the serum sickness would be extremely rare, but usually I think it will be self-limiting, more a nuisance. There have been reports of Bell's palsy, that is 7th facial nerve palsy. So people, Bell's palsy, you can see that they kind of droopy on one side of the face. They lost the control of the facial muscle. There had been some description of rarely a few individuals who had the vaccination associated with that. It's not clear what the mechanism is, whether this is true allergy or whether this is just chance event. I think that we need more follow-up and observation time to see whether this is really a real thing or not. So how effective is the COVID vaccines? I want to just put everything in the usual perspective because some people get very upset, like that you don't get 95% efficacy. So the influenza vaccine that many of you get every year, the effectiveness is about 44%, and it requires just 1 dose. There are 3 COVID vaccine that I mentioned. One is the AstraZeneca vaccine. It's a protein, adenovirus express protein, recombinant protein vaccine. They have already phase 3 clinical data. It is not been published, but it involved a lot of patients, but the efficacy is thought to be about 70%. It required 2 doses. And then chicken pox, many of you may have chicken pox vaccine, is highly effective, also require 2 doses, and the efficacy is 92%. And then both the Moderna and Pfizer vaccine are in the range of 95%. Measles vaccine is highly effective, 97%. So I just want to kind of put this in perspective that in effect, like if you have anything over 50%, it's pretty good, right? Because in fact, the flu vaccine is only 44% effective, and we still use it because any kind of protection when applied to a population level will save a lot of lives, because when you talk about population, you're talking about like 33 million people in Canada. So with such big number, even rare events become quite a significant benefit. So I think that we should bear this in mind, and then this would become apparently important, that if we want to vaccinate the population at large, it really doesn't matter whether everybody have to have 95% efficacy vaccine, but maybe even 70% is sufficient. And then later on we'll discuss, because you also have heard from the news, in some province, they've decided, for example, Quebec, to just vaccinate everybody with 1 dose, because they feel that it's much more important to protect a larger portion of the individual with low efficacy than protecting half of that number with high efficacy. And it's a difficult decision, because we have limited supply at this time. And so I think this is a potentially quite a reasonable argument. When you don't have enough vaccine to go around, everybody just get 1 dose. And then if you have a second dose, it will be delayed, and hopefully will have similar kind of benefit. But even if you lost some efficacy, at least you have a larger population that is protected by the first dose. So there are a number of areas of uncertainties about COVID-19 vaccines. It is pretty amazing that we already, like within 1 year, had developed the vaccine, finished the clinical trial, and are starting to deliver these vaccines. But because of such short time, and there's so many new things about this virus, I think that that a lot of things we don't really know for certain. So I kind of list a few questions, and I think we will also go through a number of other questions in the open forum. Related to the vaccine, an important question would be how long the COVID immunity lasts, whether it's natural immunity or acquired immunity. So natural immunity would be if you had been infected by a live virus from somebody. Whereas in vaccination is an acquired immunity artificially by exposing you to the spike protein. There is some kind of suggestive kind of data, and looking at people who had been infected with naturally, that they are looking at the antibody, neutralizing antibody, and the kind of lymphocyte that are important to mediate the body defense. And it's been suggested that at a minimum, it's around 5 to 6 months of immunity in this study. It's less than 200 patients. So there's good evidence of that, and it may last longer. It's just that this patient had not been followed for a longer period of time, but at least 5 to 6 months, which is quite reasonable and encouraging. So you may also hear from the news that there are new variants due to mutation of the virus itself, and the mutations on the spike protein, and there's more than one mutation. You can have the South African variant, which now become, the UK variants and the South African variant, and then there are other variants. And because they are present in the spike protein, the question is, how does it affect the disease? We already have heard that there's some suggestion that these kind of new variants allow the virus to infect more aggressively, to transmit more readily. But what about its effect on the vaccine efficacy? So one of the things, talking to experts in vaccine, they think that these kind of mutation will have probably relatively minor effect, because the way that the vaccine works is once you develop the spike protein, and expose it on a cell surface in the vaccinee, the antibody response, for example, is directed against multiple parts of the protein, not just one single part. So it's unlikely that if you have just one or two mutations, you will change the protein so dramatically that the antibody that are protective will not serve its function. So the third question I have, which I think is relevant to many of you and potentially people who have chronic disease, is are there any specific groups who may not get a robust immune response? So even you may vaccinate this individual, they may not get protection. Yeah, I kind of already hinted it a little bit. So a lot of things we have already learned, for example, for hepatitis B infection in the dialysis population. So we know people who are on dialysis with chronic end-stage kidney disease, the immune system is not normal. So even if they're vaccinated, they may not get an immune response that is protective. And the same can be said that if you're on high-dose immunosuppression, whether for organ transplantation or to treat an active immunologic disease, whether it's kidney or not, generally we would avoid vaccinating this individual because the probability that they would develop a robust immune protection is very low. So it may be better to wait until the immunosuppression level is significantly lower. For the dialysis population, you don't have any choice. You just have to try to immunize them, but expecting that many of them will not be protected. So one thing that is unclear, so like once you get immunized and then you have luckily got immunity, then are you home free? And then and it's really unclear because there are people who are actually thinking that maybe in the future, like not so distant, we may have a vaccination passport that allow you to go abroad. So I think the implication of that is actually unclear because you may well be protected for yourself, but it may be possible that you can carry subclinical infection and then be a carrier to somebody close to you who have not been vaccinated. So that's why I think mass vaccination at a high level population is important. And until you can achieve that, vaccinated a small percentage of population, those individuals can still, while they protect themselves, have to remember they could theoretically serve as a carrier and infect other people close to them. So this is an unknown. I think it's theoretical and more study needs to be done. And I also already mentioned about the 1 doses versus 2 doses in a setting of limited supply. And it's a difficult decision. And in some country, in some province, there are so many at-risk, high-risk individuals who will not be able to get the vaccine. So the government may decide to just try to maximize the number of people who can get 1 dose rather than aiming for the 2 doses. In Ontario, I think that our provincial healthcare authority have decided to give everybody 2 doses. But there may be some delay, as already on the news that you may hear, because of the decreased delivery of the vaccine by the Pfizer company. So I think I just want to kind of finishing up the talk to kind of just think a little bit, maybe talking out loud, like about the bigger picture, like how is COVID-19 pandemic likely to end in Canada? It's a very complex picture, I think, but I think I want to encourage you that even though it's a rough time ahead for the next 2 to 3 months, because we really are going to have probably more cases, and before it gets better, but the light is at the end of the tunnel. So from what I can understand, there is planning by the Canadian government and different provincial authorities that the high priority groups will have completed their vaccination by April. So who are the high priority groups? So these are people, residents of long-term care, provider of long-term care. This group have to be protected. Long-term care residents, so many have died because of the nature of the long-term care setting and the provider working in multiple places or bringing in community infection to infect the whole long-term care. So multiple outbreaks, unfortunately, it caused so many deaths. So this is a high priority group. Another high priority group is the healthcare worker, people particularly work in the emergency department, COVID ward, ICU, nurses, doctors, and then essential worker, people who work for the grocery store, like who have to, firemen, policemen. So, and then maybe the province will also prioritize certain group. I haven't heard about it yet, but it would not surprise me that elderly individual should also be considered as, and then maybe there's some individual who have chronic diseases that would put them at risk for severe disease. As I mentioned earlier in the introductory slide, they may all become high priority groups. So if there's enough dosage to go around lightly, then these individuals hopefully would be all vaccinated by April. And then the general public, is expected to be vaccinated and hopefully completed all the vaccination before the start of the school year in the fall. And obviously, if there's one or more new vaccine that are shown to be effective, such as the AstraZeneca vaccine, become available, or the Janssen vaccine, then this will relieve a lot of pressure of this 2 mRNA vaccine and allow more people to get vaccinated much more faster. And the faster, the better, because you also don't want to potentially have a large population infected with all these new variants, which keep on mutating. So eventually, how would we know that the pandemic has passed? And I think we will know by the number of new daily cases below a critical threshold. And ideally would be 0, but it may not be realistic. We're already using this as a metric to look at whether we have good versus bad control. But when it starts to get down to very low level, so like in Ontario, for example, if you have less than 100 cases, that is really very, very good. So that would allow a lot of easing and return to normalcy. And whether this will happen by the fall, I think it's has a good likelihood because there are 2 things in favor. One is the vaccination of more and more people. Second thing is that it does seem that after winter in the warmer weather, that we tend to have lower case load. So when summer comes, just like last summer, we were doing fairly well. Unfortunately, because this is a pandemic, it's a global phenomenon, it's not going to end until you can vaccinate a large percentage of the global population. And so that is much more challenging. And it may not happen until 2022, because logistically, like to vaccinate billions of people across all countries will be very challenging. And right now, all the vaccinations are really in only for the rich countries. The poor country really don't have the luxury. And but with the newer vaccines that are expected to come on later this year, such as the AstraZeneca maybe Janssen vaccine, maybe this will change equation a little bit. So I would say that the mitigating measures that we need to adhere to, masking, hand washing, and social distancing may still be needed for many months. And so maybe even at the end of the year, we still have to do some kind of masking and social distancing. But at least if all the schools can be open and people can have more freedom and with the proper precaution, I think that things do look a lot brighter with the availability of the vaccination effective for this disease. So I think I will end. I know that we have a lot of questions, and so I think we can go through them, and I think that would allow us to have discussions. And thank you very much.
It was wonderful, Dr. Pei. Thank you for a highly informative presentation, and I know that will just continue through this question and answer period. Just a bit of heads up, I should say, I should have prefaced this at the beginning. We are recording this webinar, and it will be available online in about a week's time. So please don't feel that you're obligated to chicken scratch a bunch of notes or anything. We will have it available, the slides, as well as Dr. Pei's smiling face, available in about 1 week's time. So I'm just going to jump right in. We have 34 questions submitted this evening and an additional 30 questions submitted ahead of today. So for those of you that have asked questions, if we cannot get to it, I will work with Dr. Pei to get those answers to you. We will do our best to cover as many questions in the next hour. And for those that we aren't able to address, Dr. Pei and I will work to get those answers out. So very first question, Dr. Pei, and again, you can only speak to what you know. There's a lot of moving parts, a lot of changes on a daily basis with respect to this vaccine, but can you speak to when you anticipate PKD patients, so inclusive of the recessive and the dominant form, as well as CHF, would be vaccinated? We know that there's a lot of questions here surrounding why aren't PKD patients considered a high priority right now, and things of that nature. Do you have any timeline as to when PKD patients will be vaccinated? Do they fall into that September general pop estimation?
I think probably my guess is like, so as I mentioned already, PKDs by itself, if you don't have kidney failure, your risk is only slightly elevated. It's really PKD patient, whether it's dominant or recessive, it doesn't really matter, that have either severe kidney failure, or in the recessive form, sometimes they can have liver failure. So those would be what I consider as high-risk group, because when they get the infection, they can get much more severe disease. I think at this time, we know that the highest group of people who will die from COVID is the long-term care facility residents. They are elderly, they often have comorbidity, and they are clustered together, and they have outbreaks. And that's why I would think that there's no disagreement between the different kind of healthcare infectious disease expert that this has to be the #1 group, because already so many of them had died. You know, like if you look at COVID mortality, more than 50% from the long-term care facility. So I think until we vaccinate everybody there, and it also would include a caregiver as well, because if they don't get vaccinated, they can bring the disease to the nursing home or long-term care facility. From the medical point of view, like after this group, then you can argue that there are other groups, and then and I'm not sure like the prioritizing of who to get next within the high priority group is not up to us physicians, is by a somewhat opaque kind of COVID table by the Premier of Ontario, and they get expert input, but it's not clear what kind of how it's not that transparent to me how they decide. But it would not surprise me like that maybe organ transplant patient like and people who particularly organ transplant patients who have been not on a lot of immunosuppressive, but have stable graft function, but they could get very sick if they get infected. Whether dialysis patient would be a high-risk group, I think they are high risk in the sense that that if they get sick, they can get really sick. But the dilemma is that they may not respond to the vaccination very well. And the same for the organ transplant patient who are on high-dose immunosuppression, or any kidney or liver or lung disease patient who are getting high-dose immunosuppressive. So whether they will kind of differentiate like within different group, like different subset of patient, like when they would get the vaccine, it's unclear at this time. But I think, and then the elderly, and I don't know how they would decide on, maybe they would have to go by a point system, or like for the healthcare worker, it's relatively straightforward. Like if you see patients and you see COVID patient, you are ahead. If you don't see patient, please wait until later. Everybody else who are at higher risk, then you can do it later. I'm not clear, like after that, like what is the, how the government will decide. It's not up to us, like we cannot recommend like someone to get a vaccine. So it go by the government's kind of guideline, and they will checklist it. And I had my vaccine last week, and then I have to go through a checklist. They will check it, what I check in the vaccination site. If I fail a question, I will get kicked out. So it's not, once they set the guideline, then I think that the selection of individual will be according to the guideline. And then when they finish a certain group, they will act on the other groups.
Okay, thank you very much. We have a question here. It's from one of your patients, actually. So she's asking, will she be on the list for vaccine from TGH, or will that come from her GP? So PKD patients that are part of a specialty clinic or that frequent their nephrologist, will they receive notification about the vaccine from their clinic, their nephrologist?
No. It will be widely publicized guideline by the government. So this, and then I'm not quite sure how they're going to actually do that. For the healthcare worker, it's relatively easy because once they identify the priority group, they go through different hospital, different institution, then the eligible individual will then get an email, and then you have to fill out a form. And then if you answer all the questions that fit you in with the right priority, then you get accepted. And then they will send you a follow-up email that tells you the exact time where to go for the first dose. And once you have the first dose, they give you the timetable for the second dose. My suspicion is because this is much more challenging if you have to do it for every patient, they may have some specific guideline kind of bullet points. If you fit through those, then you can just, you may potentially need a letter to say that, to clarify that that you fit the guideline, and that may be coming from your doctor. I'm not sure how they're going to do it, like, because it's not clear to me. So there's no discussion, or I have not heard anything that like how they would roll it out. Yeah.
Thank you. Next question. I'm taking generic tolvaptan as prescribed by my nephrologist. Has the vaccine been tested for adverse reactions with tolvaptan? Are there any
No.
effects from the vaccine that I should be prepared for while taking tolvaptan?
No, tolvaptan has nothing to do with the severe allergic reaction. As I mentioned, the severe allergic reaction is to a component of the vaccine. It's thought that this component is the polyethylene glycol, which is unique for the mRNA vaccine. So I would expect the severe allergic reaction for the mRNA vaccine may not be applicable to the newer non-mRNA vaccine that may be coming up that use recombinant protein technology, because they won't need the polyethylene glycol in the vaccine. It's only in the mRNA vaccine. And so it's generic for this class. And I think that obviously, if you have a lot of allergy, it would make you kind of worry. But I think the chance of that that you're actually allergic to polyethylene glycol because of an allergic predisposition is very low. There's a lot of people with a lot of allergy, but as I mentioned, the risk of getting this is 1 in 100,000. Okay, so I think you should bear it in mind. I would think this is a highly effective vaccine that will help to protect you from COVID. And particularly if you have risk factors such as age and kidney failure. And so the risk of the allergic reaction, on the other hand, is very unlikely. And also it's eminently treatable. So if you worry that you may have an allergic reaction, typically after the injection, they will want you to wait at the clinic for 15 minutes, and you can wait for 1 hour if you want. Just bring a book, and then if you don't have a reaction, then it's unlikely that the reaction that you may have subsequently would be life-threatening. The life-threatening one always happen very quickly, like usually within 10, 15 minutes, or even within the first few minutes.
Well, speaking briefly and quickly on the PEG allergy, as you said, which is about that 1 in 100,000 prevalency, there's an individual who is a dialysis patient, and she's had 2 allergic reactions to meds within the last year, both causing anaphylactic reactions. So she's questioning, because, as you've mentioned, the 2 that are accessible now, Moderna and the Pfizer, both have that PEG ingredient. What would you say to this individual that's asking about vaccines and the risk?
I think the cross reaction is unlikely. So if you're allergic, so she was allergic to something in a dialysis?
She's a dialysis patient who has had 2 allergic reactions to medication,
Okay.
over the last year, and they've both caused anaphylactic reactions, and both of them had the PEG in it.
Both have PEG in it?
Mm-hmm.
Well, if you know that you had allergic reaction to PEG, then you should not take the vaccine. But that is quite uncommon, because most PEG is not present in most things. Like, as I mentioned, even the other vaccines are not likely to have PEG. It's because PEG is kind of like an antifreeze, because these this mRNA vaccine are so fragile that you need to stabilize it. And so that's why the PEG is used, but it's not normally used in other vaccines.
Okay, we've touched on Jynarque already this evening, and you spoke that there was no concern about being on the medication and being vaccinated. They're asking if there should be any modifications to their dosage or anything of that capacity, or would a Jynarque patient continue on their plan followed by their nephrologist as normal during the vaccination?
So I think you should not consider this as anything. It's like a flu vaccine otherwise. So when you take Jynarque and you have a flu vaccine, you don't really need to do anything unless you get sick from it. So let's say if you have a severe systemic reaction, you get nauseated, you have fever, you cannot eat or drink, then obviously you don't want to take Jynarque because you're unable to keep up with the water intake. But otherwise, there is nothing specific that would say that these two things would have any kind of interaction. For genetic patients, anytime you get acutely ill, you should stop it, because if you can't take in water or if you have diarrhea, for example, then you can't keep up, you can get dehydrated. So that would be the only thing that I could think of. But I think it's also very unlikely to have this kind of severe reaction that make you so ill that you cannot eat or drink. So typically, if you have a more of the systemic infection, it would more feel like a mild episode of flu. Maybe some people can react badly to that. If they really cannot eat or drink, then by and large, you should stop the Genad. But most people with a mild degree of flu and you take some Tylenol, and then it will be fine within 1 or 2 days.
Okay. One of the side effects that you spoke of earlier was the muscle aches. We have a PKD patient who is very concerned about that, as she has debilitating muscle pain from nerve damage and severe neuropathy because of kidney failure and the effects of anti-rejection meds. She's had a bad reaction to a tetanus vaccine back in 2015, and it put her in a major pain flare-up for months afterwards. Do you feel with someone that is affected by peripheral neuropathy, polyneuropathy, and a hereditary form of neuropathy, will that the muscle aches be more prevalent in her as a patient than anyone else? Her neurologist, just additionally, has told her to avoid neurotoxic meds. And so she's asking, is this vaccine neurotoxic, or can it cause neurotoxicity symptoms?
No, the muscle ache is not really relevant here. Muscle ache is localized to the injection site. So you have to remember, so the vaccine, depending on which vaccine, is like 0.3 milliliter in a tiny syringe. It's injected into your deltoid, like your upper arm muscle. So your muscle is going to be sore. Okay, but it would not, so the injection site, if let's say if your left shoulder muscle that get injected, you don't expect that your right shoulder or your leg will get sore. And whether if you have a full-blown kind of flu-like syndrome, sometimes flu can cause muscle aches, like generalized muscle ache. That would be a little bit more serious, but it's transient. It's just like a flu. So in your case, if you had flu before and you have muscle ache, that would be kind of the degree of the muscle ache that you can expect in probably a relatively severe type of reaction. Like most of the time, you won't even know it. Yeah. But the local injection site, like where you actually receive the needle, is going to be sore for a few days. Yeah.
Okay, thank you. A question that came in from this evening. Hi, Dr. Pei. Thanks so much for helping us during this difficult time. I am a PKD and PLD patient and had COVID, now recovered. I'm stage 3B kidney failure. Compared to my normal 135 creatinine, I had reached 185 creatinine while in the hospital. Following my discharge, I decided to partake in the COVID research and was told that I can get it again. It was also suggested that my husband and son living at home get periodically tested. If I get COVID again, do you think I will have the same effects?
So this is one of the uncertainty, but as I mentioned, there are studies to suggest that for most patients, and I can only say, like I can only make a generalization. I cannot say every patient, but I think a majority of patients, or most patients that had either naturally infected or vaccinated, acquire immunity from COVID. My expectation would be they will have some kind of protection. If they have full protection, you won't even know that you have it, but you can carry the disease if you have minor viral shedding and then you don't get sick from it. If you do get the disease, you may get a milder form of disease because you're partially protected. So that's why so there is the immunity memory. So even though the antibody titer may drop with time, because the COVID is one time only type of thing, when you see it again, you already have the memory, and then you can make that antibody very quickly. And so that would allow partial protection. And so I would think that my expectation would be if you already infected once, next time if you do get infected, there's more chance than not that either you won't get any symptom or you'll get very mild symptom.
Okay, thank you. The next question, let's see here. Okay. My brother has one kidney after donating it. He has an allergy to penicillin. Can he be vaccinated? So someone who is a organ donor, is there any advice that you can speak to with respect to them getting the vaccine?
Yeah, so I would expect your brother's kidney function is close to normal with kidney donor, even though they only have one kidney left. After the donation, their kidney get bigger and they actually filtrate more. And so when you do the creatinine clearance, like 3 months after, they are pretty well normal. So your brother would not be expected to have any degree of kidney failure. I think that I would not expect him to have any risks more than the usual population risk based on his age and body habitus.
Great, thank you. Is it okay to get a Procrit injection the day before getting the COVID-19 vaccine?
It's okay to what? Sorry.
Get a Procrit injection the day before the COVID-19 vaccine. You know what that Procrit injection?
What kind of injection? Sorry, I didn't quite.
Procrit, Procrit.
Oh, Procrit. Okay. Yeah. So yeah, there's no bearing. They don't interact with each other.
Understood. So the allergy has, so this is a comment and a question. So the allergy has nothing to do with an allergy to bees or insects and carrying an EpiPen. It's an allergy to the PEG. Is there any way to know if you have an allergy to that ahead of time?
No, like because PEG is not a common substance used, so many people will never have exposed to PEG. I guess a higher molecular weight form of PEG has been used as a bowel prep cleaning solution for people who are getting colonoscopy. So those individuals may have some exposure. It's a higher molecular weight form, not the PEG 2000. And as I mentioned, it's a substance that is rarely used any kind of medicinal preparation, and you don't really need it for other vaccines. So it's very unlikely that you would know beforehand. But once you have the first dose, if you're allergic, then you would know. But before that, like it's very unlikely that you would actually know. But also emphasizing how rare it is 1 in 100,000. So I think you need to bear in mind it's a highly not very probable event.
Okay.
Yeah.
Do you have any insight on when the vaccine will be approved for children of all ages?
The vaccine has not been tested in children. So both vaccines, the lowest age is 16. So usually Food and Drug Administration would not approve anything if it's never been tested. So in children, there may be some new study forthcoming, but at this time, I'm not aware of any study. that actually have, so without any kind of clinical trial, you're not likely going to be able to vaccinate children anytime soon. On the other hand, as you may know, that younger people, particularly children, they seem to get away with having little or no disease or symptoms when they get infected with COVID. Uncommonly, there is a inflammatory syndrome in a few children, and that has received some kind of concern, but it is also quite uncommon. By and large, like younger individual, young adult, children, adolescent, when they COVID, they will get over it without any problem.
Okay. The next question, is the vaccine safe for people with ruptured brain aneurysms? As of right now, I'm not allowed to get the flu shot because of an increase in my headaches until I see my neurosurgeon again.
I would not think this is an absolute contraindication. I would be actually surprised that this would be a contraindication. Particularly, I think you have to weigh the risk and benefit. And like if you have a headache, so if you have brain aneurysm, and I don't know whether it's repair or not, if you have a headache, you can just take a Tylenol or take a non-steroid anti-inflammatory, it will be gone. And so I don't think this would be a contraindication. I would feel kind of concerned if you're not able to get the COVID, because potentially the benefit is so much more.
Okay. There are a few people asking, would we need to get yearly COVID shots similar to flu shots?
It's quite possible. So what is quite clear now is that the COVID, the virus is mutating. It's changing its genetic code. So, and again, with longer study, we'll know how long the immunity lasts. But very likely, though, if you are immunized, you will have some kind of partial cross protection, even if the virus change. But these are really unknown questions. I think that we warrant further study, and with more time and we have longer follow-up and more data on how long the immunity lasts, I think it would allow us to answer that. For now, I think the immunity lasts at least 5 to 6 months, but it can last longer. Whether you need a booster once in a while, I think it will require some study, like to look at, for example, the protective antibody titer, how stable it is with time, and does it drop? And if it drops to really undetectable, maybe a booster would be helpful. Yeah. So I think it is unclear right now.
Okay, go through here. How will the vaccine work with multiple comorbidities?
It's non-specific. It just protects you to get severe disease. When you have multiple comorbidity for severe disease, if you get COVID, then you end up in the ICU when the disease is severe. So the severe disease typically will be the pneumonia. And you could have clotting problem. And but if the disease get attenuated and you have a mild flu and you don't have a drop in the oxygenation, then you don't even need to come to the hospital. Yeah, so I think for COVID monitoring, in fact, I think if you want, one thing that you could really get is a oximeter. You can buy it from Amazon. Like you can check it once a day. Like so, and another thing about that is that some patient with COVID, may have little symptoms and the oxygen level drop to a very dangerous level before they crash. Yeah. So this will be picked up by the oximeter, which put on your index finger. And so that would be, it's like taking a blood pressure at home. Like right now with the COVID, it's really difficult to see your doctor in the office but you can do some kind of self-monitoring. You check your blood pressure at home with a monitor cup. And if you have a oximeter, finger oximeter, and you have developed some unexplained cold or symptoms and you worry that it's COVID, as long as your oxygenation is over 90%, even if you have COVID, you just stay at home. You don't need to come to the hospital. But on the other hand, even if you have no symptom, but the oxygen level drop unexplained, then you should at least consult a health professional.
Okay, thank you. We have a couple people asking for your definition of what would you consider a low dose of immunosuppressants and what would you consider the higher dose of immunosuppressant?
It's very difficult to say. Higher dose, so maybe the timing. So because there is no single test, typically for organ transplant recipient, they get 2 or 3 different immunosuppressive drugs. It's not that you measure the drug level will tell you the degree of immunosuppression, unfortunately, and there's no easy test for that. But what I can tell you is that probably within the first 6 months after an organ transplant, this is the highest kind of risk period for rejection. And often patients will have 1 or more in rejection and get treated with steroid, and the immunosuppressive drug is the highest during that time. So I would expect that during the first 6 months or 9 months after organ transplant, you would not respond very well to immunization. But once you're 1 year through and you have no ongoing problem with rejection, you basically on very little immunosuppression. Yeah.
Thank you very much for clarifying that. We have a question from the UK. We have been told in the UK that we have been told different vaccines could be used for the first and second jab, depending on what is available at the time. What is your opinion about that? So taking one vaccine, one type of vaccine the first time and a different one the second time?
Yeah, so it's not science-based. That's all I can say, because I can tell you is that all this data I show you are according to specific protocol. Right. But unfortunately, there are healthcare authority that decided to just do whatever is pragmatic. And so you have to get a little bit of luck that I think what you can say is that if you have one of the mRNA vaccines, even after 1 dose, you have already a very good protection, like 80%. So the second is kind of a bonus. So even if it doesn't work, it probably won't be a big deal. You already have a good share of protection. Yeah.
Thank you. I'm just going through here. I'm allergic to Cipro and the quinolone family, and will have anaphylactic shock from either of those. Not knowing the contents of Cipro and quinolones, do you think that I will have an allergic reaction to the vaccine? So I know we've spoken a couple times.
No.
Okay.
PEG is very specific. So PEG, as I mentioned, is an antifreeze. Okay, so you don't put antifreeze in your ordinary medicine. It's only because the mRNA vaccine is very tricky, very unstable and fragile that you need to stabilize it with this chemical. Yeah. So it's not present in a lot of things. So it's unlikely that you would have had it in your life, like other than maybe if you had a colonoscopy prep and you happen to have the high molecular weight PEG, then you may have drunken that like to clear your bowel, and so you may have some exposure. But Otherwise, and if you have a severe allergic reaction to that, then I would probably say don't take the mRNA vaccine.
Okay, thank you.
I do see a question maybe I can answer. I
Okay,
think
yeah, go right in.
yeah. So it says, how is the vaccine metabolized? So I think what you mean is the mRNA vaccine, right? So not because different vaccine are metabolized in different ways. So the mRNA vaccine, so the mRNA, as I mentioned, is highly unstable. It's a message that get degraded. So it's once it get into the cell, it get read multiple times within a certain time period. And then it get degraded by the normal cell machinery. So the mRNA is not going to hang around very long, but during the time when it's still active, maybe a few days, let's say, it's going to ramp up the cell's machinery to make this spike protein and get them to the cell membrane to trigger an immune response. So that's how. So you don't have to worry that it's going to hang around for a long time. One of the concern is that there's people who are concerned about DNA vaccine. So DNA is the message more permanent. If you get incorporated in the genome, then it will be there permanently. Whereas messenger RNA, a transient message that is impermanent. So it doesn't hang around. So you will not have the viral mRNA after a few days. But during that time, your body will have made a lot of spike protein and activate the immune system to help to protect you.
Okay, there's another question. Can a person be tested to find out if they've had the coronavirus unknowingly to see if they have the antibodies?
Yeah, so there are two ways to find out about testing. One is testing of whether you have an active disease meaning active virus, the likelihood, and that requires the RT-PCR. So it requires you taking a nasal swab, and then they see if they can identify, amplify the messenger RNA from the sample. So a positive RT-PCR generally means active viral replication. But your question is about whether you could have an infection in the remote past. So that would be the antibody test. So there's another way of testing. So about the COVID antibody, like once you have an infection, you have an IgM and IgG antibody response. IgM would mean a recent infection. IgG would be remote and not recent infection. Yeah. Unfortunately, these kind of tests is not readily available at the moment, but it will be necessary eventually and will be needed to test large population so that we know like whether we reach herd immunity, for example. So let's say 70% of population have an IgG antibody titer that is indicative of past infection, that you know that your population have herd immunity. Yeah. You don't need to test like 33 million people in Canada, but you could sample to get an idea like what is the probability that you have 70% in population level, like randomly selected. It's like doing kind of a random sampling, and that would allow you to get a handle. But unfortunately, a lot of these tests also are problematic because they cross-react with the common cold, like coronavirus. There are certain subtype that cause a common cold, which is very common. So you want the test to be also specific for COVID-19 and not the common cold. Yeah, so that is the problem right now. So the testing is not that ideal, like, yeah.
Okay, the next question. Is there any indication that the virus can remain dormant in a carrier? And if so, for how long before dying?
typically, the virus, I'm not aware of kind of chronic carrier stage. Like when you get infected, your body mount an immune response, so the virus will be getting rid of. And so there is more detailed kind of study, smaller scale study that have shown that the highest risk period of spreading infection is 2 to 3 days before you have symptom, and then probably up to 7 days after you have the symptoms. And after that, the viral load kind of drop because the immunity kick in, and then you get rid of the virus. And in fact, so even though we ask people to quarantine for 14 days, actually by 7 days, pretty well, most of the infectiousness is gone. You may still be able to demonstrate the RT-PCR testing, like mRNA, but it may not be a live virus. It may be a dead virus that you detect, and the chance of infecting other people are extremely low. Yeah.
Okay, thank you. If someone is asymptomatic and has COVID, is it safe to get the vaccine?
If they're asymptomatic and they have an RT-PCR test to confirm that they have COVID, then I would say maybe leave it to somebody else who need it more than you, because you already have the protection. You don't really need it.
Excellent point. Let's go back to the top here. Of the 3 vaccines, which one has a positive impact on CD4 and CD8 T cells?
They all have, so there are studies on these vaccines that, so there are 2 kinds of immune response. One is antibody, so I kind of alluded, and then a CD3, CD4, CD4, CD8. And so these are referred to lymphocytes, and there are different kinds of lymphocytes, the helper T cells, the suppressor T cells, and then the killer T cells. These are also part of the immune system. They work in different ways. Antibodies work in blocking the spike protein so that the virus cannot get attached to the cell to infect the cell. But once the virus infected the cell, then the cell-mediated immune response can detect it and then attack those immune infected cells. So they kind of work kind of differently. And so the study that I mentioned about immunity lasting like 5 to 6 months, using like sophisticated testing of antibody and also the T lymphocyte subset of patients who are infected, and over time, and then to see whether this kind of immune memory is intact. So up to 5 to 6 months in the study is still intact in the majority of the patients. So most patients would have a good kind of immune memory for that time. It may be longer. It's just that like COVID has only been with us for like maybe just over a year. And so those patients, they don't have long enough follow-up.
Okay, at this time, do you know of any Canadian studies that are happening in regards to transplant patients with respect to the vaccine, or possibly how one would find that information out?
I don't think, so these studies are not typically done by individual investigators. They're done by the drug company. Okay, so it's unlike some drugs that are used to treat COVID, in which you can kind of get compassionate release. Vaccine is completely different because you have proof that it has to work first. So I'm not aware of any kind of sub-study. So in drugs like Remdesivir, and dexamethasone, these kind of drugs. The first one is made by a company called Gilead Science, and they give out these drugs for researcher, like to make their own study. But for vaccine, because it's unlikely that if you want to do a research, you have to see the purpose of research is to demonstrate efficacy. As I mentioned, it takes a large number of patients to demonstrate that. So it's unlikely that any single center can do that. I'm not aware of any one doing this type of research, but I think if you're interested, like all the clinical trial have to be registered, like with the US government, they have some kind of website, clinical trial website, so you could scan through it to see if there's any vaccine clinical trial. There were vaccine clinical trials that are sponsored by the NIH and Pfizer and Moderna, and they were in collaboration with investigator, but they are part of this very large scale study, like up to 40,000 people. So these studies are done. So I think that what they're doing now is to follow up on this big cohort, and they may eventually do some other study, for example, like children, that you can get enough cases. But I'm just not sure about organ transplant, and so I don't know. And but if you want to check, the way to look for it would be the clinical trial registration by the U.S. government. There's a website.
And we can share that. That's also available on npkd.ca, the clinicaltrials.gov website. So people can stay connected with that on that level. The next question: how will the vaccine affect patients with MS? Do you have any input into possible complications to the vaccine in MS?
There's nothing specific about, you mean multiple sclerosis?
Yes.
Yeah, okay. There's nothing specific about multiple sclerosis that would kind of make it a red flag to get COVID vaccine. So I wouldn't expect anything.
Okay. Can you address children? And we've spoken about this a bit already, but we'll touch on this element of it. Can you address children not getting vaccinated and how this affects the herd immunity?
So herd immunity refers to a concept in which you still have a virus kind of circulating in a population, but at much a lower level and at such an attenuated state for most people. And the relevance of herd immunity is that because of these two features, the virus is not going to impose a significant healthcare burden to overwhelm like the ICU and hospitalization. So that's the main concept about herd immunity. It doesn't mean the virus is not there. It's going to be with us, just like the cold. And so we have to get used to it, whether we like it or not. It's just that most people, when they catch COVID, it will be kind of like a bad cold. They won't end up in the ICU. That will be allow you to have confidence to have an open society. Whereas right now, because we have never seen this virus before as a species, it really, everybody have not protected. And even like 1% to 2% mortality rate, when you look at billions of people, a lot of people die from it. And then like 5% of people ending up in the ICU. Again, it's a massive scale, right? So you overwhelm the whole healthcare system in all countries. So I think that the unintended consequence of the COVID that actually is not well recognized, but I think we are just starting to understand, is that the harm by the COVID is not just the COVID patient, but other patients with chronic diseases whose access to healthcare is denied because of COVID. And many of them actually die, like cancer patients who cannot get chemotherapy, and people with critical surgery when they cannot get surgery. Yeah. So there's a lot of bystander kind of damage, not directly related to COVID, but because COVID overwhelmed the healthcare system so much. Like, for example, now because of the lockdown and the high case rate in our hospital, all surgery are reduced by 80%. So, and that is to make sure that we have enough ICU bed to treat COVID patients. So all these patients who need surgery because they have been waiting, again, they have to keep waiting again, and some will die because they cannot wait indefinitely. They have serious problems.
Valid points, thank you. Next question. I'm a PKD patient over 65 with a creatinine level close to 150. Am I correct to assume I would be in the same priority of people over 65 and not receive the vaccine any sooner than that, despite having PKD?
So probably you're at a little bit higher risk than just age alone, because you do have a higher degree of kidney failure, but not as much risk as someone who is on dialysis. Unfortunately, this kind of risk is not all or none, it's a continuum. And so the degree of kidney failure, when you have very severe kidney failure, you definitely will be in the higher group. But when you have moderate kidney failure, you could still be at a bit of risk, but not too much risk. Yeah.
Okay. Next question. You've commented on the synthetic vaccines, so Pfizer and Moderna. Are there live COVID-19 vaccines currently being developed, and what ones would be safer for PKD kidney transplant patients?
As I mentioned, I would regard both as equivalent. So I think if you can get either, I would take it. The problem is the supply is so limited right now. You will be lucky to get it. So if you offer one, don't refuse. I want to I look at one of the comments I just want to make. Both Pfizer and Moderna vaccine, they are not live virus vaccine, I want to emphasize. So live virus, meaning that you have a virus that have a fixed number of genes. It's certainly not one gene, and that are replicating, that can self-assemble into a virus. So this vaccine just have one single molecule of the messenger RNA that is programmed to make one specific protein, the spike protein for the virus. It doesn't make the virus, actually. It just makes one protein on the surface of the virus. But this protein is critical for the virus to enter to infect the cell. So if you don't have that protein functioning property, then the virus cannot go into a cell and infect it. So they are not live virus vaccine.
Okay, we have a few more questions and a few more minutes, so we'll try and time this just right. There's a question in the chat box. It's discouraging to hear that end-stage PKD patients will not be protected despite receiving the vaccine. How do you recommend these patients manage the stress or anxiety of contracting coronavirus, particularly knowing that they may not be protected, yet the virus will still be prevalent?
So sorry, I just want to make sure I caught your question. Patient with end-stage kidney disease?
Yeah, so they're end stage. They're discouraged to hear that once you're vaccinated, you may not be fully protected.
Yeah.
So what they're asking is, how do you recommend patients manage the stress and anxiety of getting the virus or potentially getting the virus after the fact? So mentally, emotionally, how do you suggest one handles the anxiety of possibly getting the virus?
Well, I would say, so I think that I'm making a generalization when I talk about the development of immunity in end-stage kidney disease. It's not an all or none type of phenomenon. But in general, people who have end-stage kidney disease, they have abnormal immunity. Their immune system is not normal. So they don't, many patients don't mount a strong immune response, okay? So I just want you to be aware of that so that if you, let's say, have end-stage kidney disease and you have a vaccine, don't assume that you are protected. But what I did not say is you are not protected. Okay, so there are two different things. Okay, so one is that many patients may not get the same degree of protection, but can you get a little bit of protection? I mean, it may be possible. Okay, so that's why we still vaccinate people with chronic hepatitis B when they're on dialysis. Yeah, some patients do convert, but many don't. And some patients do get protection. So, and it's difficult to know why one do that and another don't. So that's one thing. So, I mean, eventually, I think if you do get offered to the vaccine, I would take it. But there's no guarantee you will develop immunity. But there may be, if you're, that you may get some partial protection, maybe not strong enough, but still it could help to attenuate the disease a little bit. When enough people take the vaccine to achieve herd immunity, like you will be protected, the chance of catching it from a random stranger will be reduced significantly. And still, as I mentioned, like practicing the mitigation strategy is going to be with us for a long time. So I would say whether you get the vaccine or not, you still need to wear a mask, wash your hands multiple times when you go to the dialysis unit. And mental health is difficult, I think, and I can understand your anxiety. But this is not generic. I think we are all facing a lot of mental health issue with COVID. And I think that just to have more positive thoughts. And so what I said is not all or none. So I want to emphasize that you may still get some partial protection. And but also when enough people get vaccinated, you will be protected in a large way.
Do you have any insight into whether or not cancer survivors should take the vaccine?
There's no reason why not, because again, it's like an organ transplant recipient. It really depends on what stage of cancer you have. So if you have an active cancer, an acute leukemia, and you're being hit with a lot of immunosuppression, there's a good chance you may not respond to the vaccination because you're immunosuppressed. But if you are, by definition, a cancer survivor, you already have been through the treatment and presumably your disease is in a remission or control state, then I would assume that you're on minimal amount of therapy. Your immune system is minimally suppressed. And there's a good chance that you will have a good, robust response to the vaccination.
I think, Dr. Pei, believe it or not, I think that covers the majority of the questions that we've had for this evening. So unless you have any more insight to add to an already very insightful presentation, I think we're safe to start wrapping up.
Yeah, I see two questions maybe I can answer because they are really very good questions.
Sure, go right ahead.
One is the serum sickness usually caused by animal products in drugs. And so I think, so serum sickness is a little bit different. So in serum sickness, you could get hives, but the mechanism is a little bit different. And the serum sickness is due to the production of some kind of antibody antigen complex. And then it triggers the immune response. and it's usually delayed. It's usually at least 2 weeks because you have never seen that antigen, and which is the allergic kind of stimulating agent. So you need the antibody response, which usually takes 2 weeks. So you could get hives from that, and back bouts of hives, and it's related to complement activation. But this kind of hives usually is painful rather than itchy, whereas the IgE-mediated hives or urticaria is related to IgE on the mast cell that get kind of stimulated immediately on exposure to the antigen. So it's the immediate allergic response that I mentioned. And this kind of hives are typically itchy rather than painful, and it's immediate. And so the two kind of hives can be very similar, but they're actually very different. And there was a question about cytokine storm. So all night I've been talking about like people who are not getting a robust immune response because they are immunosuppressed of the medication or because of their disease state. But in this case, the question regards to cytokine storm is why some individual who are infected with COVID had a devastating outcome with multi-organ failure. And they include people who are otherwise young and healthy that you wouldn't expect. And in fact, the majority of young and healthy individuals with COVID, they do extremely well. But there are also a few young and healthy that end up in ICU with multi-organ failure. And it's thought to be triggered by an overwhelming response to the COVID antigen, and probably someone who's genetically predisposed, because this is really quite unusual. So we don't really understand this phenomenon, but this is well described and is well observed clinically.
Okay, a couple last minute questions here. One is, do you feel there is a cause for concern for kidney disease patients facing a future kidney transplant by taking the vaccine?
Taking the vaccine? No, not at all. Because as I mentioned, the effect of the vaccine is temporary. Like you're not going to get any kind of foreign protein in your body after 3 or 4 days. The mRNA is completely degraded. What you do have is expression and transient expression of the spike protein in your cells. Those proteins will also be gone, like they turn over, and when the cells die, they won't be reproduced, and the new cell will not carry it. But it's during this temporary period of several days when the protein gets stuck on this cell membrane that the body's immune response scan and recognize that they're foreign and develop the immunity so that you can fight COVID the next time. So these effects will not last, and there's no reason to expect them to last. And so I think that it would be highly irrelevant to whether what you do in the future, like and this kind of vaccine effect, the stimulus to elicit the immunity will be gone, but the immune memory will be intact, and that's what it counts when you see the virus again in the future that help to protect you.
Okay, for the last question, we're at 9 o'clock on the nose here. So for our last question, Dr. Pei, I did get SARS in 2013 and another time last year. I would like to know if I'm immune to COVID-19.
Yeah. So you had SARS. SARS is not, you had SARS-1, okay? So that is a slightly different virus. It's still coronavirus. So whether you will have some cross-reactivity to COVID-2 or not is unclear. But if you had COVID, so this would be SARS-CoV-2, okay? So it's a slightly different virus, okay? But it's in the same family. If you had it last year, for sure, that means you already had immunity. Okay, where SARS-1, I'm not sure, and but there's also a literature which is very interesting, and it may, as we learn more about the COVID, it may allow us to explain why there's so many asymptomatic cases. So these are research that is just coming out, and so why are these people who get infected with SARS have no symptom, clinically asymptomatic? And what they find is that they have previously had antibody response to other coronavirus. As I mentioned, coronavirus is a large family of viruses, and some of them actually are responsible for the common colds. And so it is possible that there may be some kind of cross-reactivity, and that may explain why some people seem to be have no consequence of the COVID infection. So this is a hypothesis that require more work. And so it's similar to what you're asking, like the last questioner about the SARS-1 and SARS-2. And but since in his or her case, because she both SARS and SARS-1 and SARS-2, you have it. So that means you are protected. So I cannot say, but for sure, you have SARS-2, which is the SARS-CoV-2. It's the COVID-19 virus.
Okay, thank you. Dr. Pei, I'll just get you to click on my video to make me the host again, just as we close out for the session. I do want to thank you on behalf of the PKD community on an international level, wholeheartedly for your continued support of the PKD community, for your time this evening, and for preparing this presentation. It's been absolutely highly informative, and we thank you very much for joining us this evening.
Well, thank you very much. My pleasure.
We do have, when I've regained access as the host, we do have one slide to share with those that are still on here. Dr. Pei, have you switched me over to host? There we go. Let's see here. You just click on my video, right click on me.
Change host.
There we go, we got it. Okay, so what we're going to do here is we're just going to promote an upcoming presentation with the one and only Dr. Pei. So our friends at UHN are holding a presentation on February 25th from 12 p.m. to 1 p.m. It's going to be on polycystic kidney disease diagnosis and treatment options. So the link has been shared on our social channels already. We encourage you to sign up and register for this event as well to learn more from the one and only Dr. Pei. Again, and this is a webinar that's being presented by the University Health Network. So even during a lockdown, you're a very busy man, Dr. Pei.
Okay.
Thank you very much again, and thank you all for joining us as it looks to be a continued year of online educational opportunities. Please stay connected with us. We will be having additional webinars throughout the year, and we hope that you will be able to join us again. Until then, stay warm, stay safe, and stay healthy. We'll see you all again. Bye-bye. Bye, Dr. Pei.
Bye-bye.